Hello everyone, Dr. Alex Vasquez here with the next video in our program on human microbiome and dysbiosis in clinical disease. Today I am going to focus on solutions for dysbiosis in the location of the gastrointestinal tract. I'm sure that for most people, when they think of dysbiosis, they typically think of gastrointestinal dysbiosis, even though of course now we appreciate dysbiosis can occur in multiple locations, even at the same time, even of course in the same patient. And in those different locations, typically we encounter different microbes that each play their role in contributing to dysbiosis-induced disease. Gastrointestinal dysbiosis, I think, is arguably the most common type of dysbiosis. And that's because we have so many different influences on the microbiome of the gastrointestinal tract, such as exercise, nutritional supplementation, diet, of course, stress, and because we appreciate the clinical manifestations of gastrointestinal dysbiosis because the gut microbiome has the potential to have the greatest impact on human physiology and pathophysiology by sheer volume of the microbial population and the resulting microbial debris, which we talked about in video number 1, and also the microbial metabolites, which I've discussed several times now throughout the program, perhaps mostly in video number 2. And we'll talk about those more, both the microbial debris and the microbial metabolites, in the last video of the series, which will be on the gut-brain connection. Course objectives are going to be described here. Of course, the ultimate goal is enhanced clinical and intellectual acumen. Your participation in this presentation and study of the materials should enable you to define dysbiosis, eubiosis, and the associated terminology in immunology, microbiology, and pathophysiology, explain the role of multifocal polydysbiosis in metabolic and inflammatory disease, analyze, interpret laboratory results for significance and or lack thereof. And what I'm aiming for there is the judicious analysis of laboratory tests, not just going for what appears to be most obvious. Identify actionable alterations in microbial patterns and the associated phenotypes of dysbiosis-induced disease. Demonstrate, of course, skill in clinical reasoning. Implement treatment plans consistent with the 4 main components of evidence-based medicine, which I've reviewed previously. And we also need to have the ability to reject distractor data, non-actionable data, or inaccurate and bogus data as well. As many of you know, I have a strong interest in education, psychology, philosophy. This is a very interesting article, a very classic study published in the Journal of Personality and Social Psychology in 1999 by Kruger and Dunning. Some of you may be familiar with what is sometimes called the Kruger-Dunning effect or the Dunning-Kruger syndrome. Basically, when people are incompetent, they don't realize they're incompetent, but they think they're competent because they don't have enough self-awareness to judge otherwise. One of the interesting things about this particular study, which included several different experimental components, is that in the 4th part of the study, what they actually showed, or what they attempted to show, was that when people are better educated, or when they receive education, even a little bit, I think the study sample, for example, included 10 minutes of instruction. Even when people receive a little bit of instruction, they actually do become more competent and also more aware. At least some people do. People who are extremely incompetent do not improve even with more education. However, people who are marginally incompetent, kind of in the gray zone between competence and incompetence, those people actually do improve and they attain better ability to reflect as well. Also, in my personal interest with regard to education and cognitive intellectual abilities, one of the things that I'm particularly interested in is pattern recognition. And in a book on a completely different topic, a book by Josh Kaufman titled The Personal MBA, he actually has a section in there that talks about pattern matching, very interesting in my opinion, and his description of the enhanced abilities that people have after they've gone through, for example, a lot of education or when they have lots of experience. What he states here, and I'll read it to you in just a moment, What he states here is that as people learn more and as people gain more experience, their ability to pattern recognize is enhanced, and that's why they have enhanced performance above and beyond their level of education. So, as I stated in the box on the right hand side, this is how learning anything always exceeds itself if applied with effort. And what I mean there is to state that learning information provides abilities beyond the cognitive acquisition of intellectual information. So when we learn things, we don't simply learn information. What we learn when we learn accurate information, especially if it's to a certain level of detail, I would imagine, what we actually gain is not simply information, but the ability to recognize patterns, and we can apply those patterns to other experiences in life and perform better in those situations as well, even though we may have learned something on a completely unrelated topic or in a different subject. So let me just read to you what he said, which I found very interesting. The more accurate patterns you've learned, the more options you have when solving new problems. Pattern matching is one of the primary reasons experienced people tend to make better decisions than inexperienced people. They've learned more accurate patterns via their experience. Having a larger mental database to draw from is what gives experts their expertise. And then secondarily, he says, pattern matching is one of the foundational capabilities of our mind and how it works. The more accurate patterns you have stored in your memory, the more quickly and accurately you can respond to whatever life throws at you. So some of you may find that interesting. Obviously, I did, which is why I added it to the presentation here. So let's move on and talk about solutions to gastrointestinal dysbiosis. This is my page of notices and disclosures. Everything, of course, is copyrighted. Some of it's protected by a trademark. All of this is educational information for clinicians. I have worked as a researcher and consultant lecturer for Biotics Research Corporation. Some of the treatments I describe might be considered off-label per FDA guidelines or definitions. So prescribing clinicians will have the ultimate responsibility in determining the appropriateness of drug prescribing per patient. We've been talking about different locations of dysbiosis, as you can see in this graphic, which we're going to relatively quickly bypass. I noticed maybe last year, I guess it was in 2015, I heard that a supposed functional medicine expert was going around saying that we were all born sterile and that we later acquired the microbiome and ultimately, in some cases, dysbiosis. Actually, that's not true. And now we've got certainly plenty of data. I was reminded of that statement when I saw some of these new reports, which is why I included it here. Nothing in the human body is sterile. And at no point in time are we as humans sterile or germ-free. So you can see the newer reports showing that the placenta has its own microbiome. And you can also see from scientific reports in August of 2016, the microbiome of aseptically collected human breast tissue in benign and malignant disease. The breast itself has its own microbiome. Breast milk has its own microbiome. Breast milk also transfers intact dietary proteins for that matter as well. But certainly we are never sterile. We always have a microbiome. So again, today we're going to focus on gastrointestinal dysbiosis. It is the most varied and quantitatively most important. So again, you've got pounds or kilograms of bacteria in your gut. You certainly don't have that quantity in your nasopharynx, genitourinary tract, or on your skin for that matter. So the potential impact of the gastrointestinal microbiome is massive, and that's why we see so many different clinical diseases associated with, causatively associated with, gastrointestinal dysbiosis. Of course, we've seen many of these concepts now come into kind of popular or public knowledge. Here's an article from 2015 in The Atlantic talking about gastrointestinal dysbiosis and how it can contribute to rheumatoid arthritis. You know, some of us were writing and reporting on this, maybe 12 years ago, 20 years ago. I published a rather important paper in 2006 that reviewed many of these concepts, but now we see that they are finally, 9 or 10 years later coming into public knowledge. This was another very impressive article from 2007, Is Rheumatoid Arthritis a Disease That Starts in the Intestine? A pilot study comparing elemental diet with oral prednisolone. What they concluded here, perhaps I should say, well, it is their conclusion, it's also their interpretation. When they applied an elemental diet to these patients with early rheumatoid arthritis and found benefit, their interpretation was that the elemental diet was relatively devoid of common allergens, and therefore the improvement in these patients was due to allergen elimination. I would state, and I think this is perhaps more accurate, that a better way to interpret the results of their study is that by use of an elemental diet, they were able to change the microbiome specifically and most importantly by reducing the total microbial load within the gut, because an elemental diet by definition is easy to digest and absorb and therefore doesn't leave a lot of residue in the gut for the microbes to consume. So it basically serves in a similar manner as would carbohydrate restriction or fasting to reduce the microbial quantity in the gut, and I think that's probably how these results were effected. I mentioned previously evidence-based medicine, evidence-based healthcare. These are the main pillars of evidence-based healthcare, not simply research. That's part of the reason that I include this slide in my presentations, is because a lot of people use the phrase evidence-based medicine or evidence-based healthcare, and they're talking about research. Of course, the larger studies that reach a lot of significance and have large sample sizes, for example, lots of subjects, those are typically multi-million-dollar studies, and of course, those are funded by drug companies. So when we say that evidence-based medicine equates to large studies, we are basically saying that the only data that we can use for evidence-based medicine are studies that are sponsored by drug companies. So we don't want to say that, and it's not true, but that's a common trap that's laid for people to fall into. So evidence-based medicine includes published research, clinicians' expertise and experience, patients' preference and autonomy, and clinical circumstances as well. So in this presentation, I'm going to talk about antibiotic and antimicrobial drug treatment, and so therefore we need to describe some of the considerations with drug prescribing. We can look at practice guidelines, for example. We can look at regional or hospital microbe profiles. So for example, in certain hospitals might harbor given strains of particular microbes, and so each individual hospital may have its own profile based on culture and sensitivity, for example, for which antibiotics might be useful in a given hospital facility or within a given community. Culture and sensitivity results are generally considered the standard. We can also look to establish long-term practice, such as, for example, the use of amoxicillin for acute otitis media. We can also look at published data from clinical trials to case reports. And we take all of that into consideration, of course, with the patient's individual tolerance and sensitivity. So not simply the microbiome or the microbe sensitivity, but also, of course, what the patient may have had an adverse reaction to in the past. Even under the best circumstances, treatment failures are not uncommon. And so we're going to talk about some ways to manage all of those considerations without having decision paralysis keep us from taking action, especially within the first 1 or 2 visits, perhaps with or without laboratory assessment. So my goal is to always be able to take action, because action is what makes our patients get better eventually, whether it's action that they take or action that we take. Laboratory tests don't cure people. Laboratory tests only provide information to educate our actions. But we don't want to be intellectually paralyzed by our dependency on laboratory data, for example. We need to be able to take action without laboratory data, even when we're treating dysbiosis, and I'll show you some ways that we can do that today. On this slide, I provide a good amount of text, so you're welcome to pause the video and take a read of what I state here. In the third paragraph, I again reiterate, don't become dependent on laboratory testing for every clinical action you take. These are just some concepts and considerations. Here I made a list of rights and wrongs in the assessment of dysbiosis. We definitely don't want to think that dysbiosis treatment always requires drug antibiotics, because in a lot of cases patients don't need drugs. We can always use nutrients, we can use botanicals, we can support immune function, we can support immune tolerance. we certainly have many options that we can select from other than simply reaching for a prescription pad and prescribing antibiotic drugs. Even though, for many of us, that's how we started off in clinical practice, was kind of a search and destroy approach. And I think that with time and more science and more experience, we've learned to not reach so readily for that prescription pad. On the other hand, just like we don't want to be overzealous about antibiotic drugs, we also don't want to be overly dependent necessarily on botanicals, diet, and lifestyle. Sometimes people do need antibiotic drugs. So we need to have balance in that conversation and appreciation for the merits of both sides, as we might say, and also the ability to analyze and appreciate each situation for what it is. If you have, as a clinician, if you have a routine, then to some extent, even though we all need to have routines, we don't want to have our routines override the nuances of the clinical situation. So I suppose we might say that we need to have an actionable routine, but we also don't want to be trapped by our own routines because we don't want to always reach for drugs. We don't necessarily always want to reach for diet, lifestyle, botanicals either, if that particular case does warrant antibiotic drugs. I don't want us to think that laboratory assessment, including culture and sensitivity, are always needed, and the data certainly supports that statement, which is obviously why I included it here. If you look at many of the studies, for example, using Bactrim to treat ANCA vasculitis, using cephalexin to treat atopic dermatitis, those studies are based on the research showing the association, in this case with both of those diseases, with Staphylococcus aureus. And the research studies that are published may or may not have included culture of those individual patients prior to treatment. However, in clinical practice, whether the original studies used culture or not, we don't have to use culture because, first of all, a lot of the studies didn't use culture. They just treated the patients empirically based on previously published research, and they still had safe and effective results. But again, we can look at the patterns that are published in the research, and we can look at patterns with which our patients present and make decisions based on those patterns, again, without always having to rely on individualized microbial assessment. Now, as we kind of ramp up, let's say, or ante up the therapeutic intensity of our programs, then I think that that does require a higher level of skill, a higher level of communication. Again, not necessarily laboratory analysis every time, but certainly that may have a role. For example, what I'm talking about, or at least what I'm thinking about, and we'll now talk about, is when we transition, let's say we start out with an antimicrobial agent such as berberine. It's very effective. It's not always effective, just like nothing's always effective. But we can use berberine empirically without laboratory assessment and see if we get the result that we want. If we don't get the result we want, we may go to another antimicrobial agent, let's say augmentin, for example. So with berberine, the risk of using berberine is almost zero. I don't think I've ever seen a patient, and I've never seen any reports of adverse effects to berberine using, for example, 500 milligrams 2 to 3 times per day for a limit of about 3 months. I've never seen adverse effects reported, and I've never seen adverse effects in my clinical practice or among friends and family who have used the same thing, including myself. However, we wouldn't say the same thing about augmentin. Some patients do have negative consequences from augmentin, just like they may have with tetracycline or doxycycline. So, for example, as we ramp up our therapeutic intensity, going again, in this case, maybe we started with dietary modification, then we added berberine. Now we're talking about drug antibiotics. We're going with augmentin, maybe doxycycline, tetracycline. As we intensify the power, and in this case specifically the prescriptive power, we might say, of those agents, then we do need to have more justification. We do need to have additional conversations with our patients about risk-benefit ratios, etc. If you were to then go to the next level, let's say metronidazole, for example, then at that point, of course, you do need to have even more justification because adverse effects with metronidazole are certainly more common. So as we increase our therapeutic intensity, we also need to reconsider at each step or at each increment the risk-benefit ratios and the associated conversations that we need to have with our clients. So I want to emphasize the fact that yes, indeed, empiric treatment is well supported by clinical trials and literature reviews. We, of course, have to apply that information with good clinical judgment per patient. Also, of course, in all forms and shapes of medicine, and also including within the complementary and alternative medicine world, including the functional medicine world, most articles and presentations that you see in conferences are presented by people who are funded by laboratories. So, of course, they're going to hold paramount what we might call the law of the laboratory. So, a lot of practice guidelines